So that's a bit better. We got it recorded as well. So yeah, so tumor metabolism. So we have the most common one is FDG, but we know it's non-specific, and it can have increased uptake when all sorts of things are happening, like post-surgical or post-chemo inflammation. But we also do know that as the cells become more hypoxic, they need more glucose. So there's quite a good correlation between tumor hypoxia and glucose uptake. As the cells become more hypoxic, their glucose drive goes up, and we can exploit that. And that primarily is probably what we're seeing when we're looking at FDG uptake in a tumor. Now, some tumor sites like prostate don't really like glucose very much. They prefer fatty acids. So C11 acetate or something like that would be better, or C11 choline. Now, choline is interesting because it is a metabolic agent, because it is part of the Krebs cycle, but also it's used in building cell walls. So it's a sort of mixture between a metabolic agent and a cell turnover agent. So thinking about choline imaging, so we can use this in a range of tumors. This is a patient with a lung cancer. And what we were doing here, we were looking specifically at the sort of cell wall growth of the tumor. And you can see that you've got a very large tumor mass here. And you have a ring of uptake around the edge of that. And this is the, basically, this is the dividing edge of the tumor. So if we did an FDG, the whole tumor might be hot of FDG because it's still metabolizing, but the growing edge is what we're finding with the choline. So it's really trying to define where the tumor is at its most active. So cell turnover, we think this is more cancer specific, but again, it needs context. So for example, if you had a recent operation and the area was healing, they would have increased cell turnover. So it's not as specific as we like to think it is. And things that work well are things which are either based on amino acids or on DNA, like thymidine or tyrosine, because these are built into new cells. And inflammatory cells tend not to do that. Inflammatory cells tend to be metabolically active, but they're not necessarily building new cell walls and new nuclei, new bits of DNA. However, of course, the problem is with this is that the bone marrow does have cells that do that normally. Otherwise, you'd all be anemic and have no white cells. So whilst with FDG, you have uptake in certain organs like the brain, which is annoying if you look at brain tumors. If you're using these agents, you'll see bone marrow uptake, which means you can't use this for looking for tumors that originate in the bone marrow or metastasize to the bone marrow. There's a range of these tracers, and I'll show you them in a second. So this is FLT Flurothymadine, and this is very specifically looking at cell division. So here we have a patient with a breast cancer. The patient has been imaged lying on their front, which is why it's sort of upside down. And you can see it's a bit confusing because right is left and left is right. But this is the right breast here. And you can see that there is a sort of, if you look very carefully, there is a sort of mass here, a round mass. And that actually does take up the thymidine. Here is uptake in bone marrow, as we said, because bone marrow is got active cell division. And this was part of a project to see whether or not we could shut down cell division with certain chemotherapy agents. So I'm not suggesting we'd use this clinically, but it is quite useful research agent. So tyrosine is slightly different in the fact that what we're doing here is that we're looking at amino acid. And the reason amino acids are quite useful is that the brain doesn't really use amino acids. So Amino acids only really go into the brain if there is a damage to the blood-brain barrier, and that occurs either at sites of tumor and less so at sites of infection. So here we have from Germany a patient, the top patient of number 1 has had a glioma which has been removed, and they're now want to know if there's any recurrence. And if we look at the MRs of number 1 and number 2, they're identical. So number 1 has true progression and has uptake of the FET. Number 2 is pseudoprogression, it's just inflammatory change, and there's very low uptake. So using this, they were able to determine that they could differentiate between pseudo progression and progression in this paper from 2009 with FDG in 35% of patients, and this is in the brain, not elsewhere. But with the FET, it was positive in 90% of patients who had recurrent tumor. So C11-methionine works in a very similar way to an amino acid, and again, it's been primarily used in brains because in the brain, the only malignant cells really grow and divide. There is a slow division of some of the glial cells, but it is very slow. So compared to normal brain, you get a very high uptake if there are dividing tumor cells, unlike FDG, where it could be lower, the same, or higher than normal brain. And again, it's been primarily used to look for these sort of post-surgical recurrences. And this is a patient. The image is from a patient from Cambridge, but I'll talk about this paper first again from Japan. And these are looking at patients who had surgery and radiotherapy. And in terms of finding recurrent disease, they compared the sensitivity with MR, and they were both very good in terms of sensitivity, but the C11-methionine was much more specific because it didn't really have uptake in inflammatory pseudo-progression, but only in progression. You can see here in our patient in the panel on the left, you can see you have almost no uptake in normal brain, but on there's the bit of brain that's been cut out, and on the anterior edge of that resection margin, you can see a small area of increased uptake of C11-methionine, and that is unfortunately some residual tumor has been left behind, which is now progressing. The problem with C11-methionine, I mean, we could use C11-methionine instead of FDG, except for a couple of problems. The biggest one is the 20-minute half-life. So you would need to sort of run the cyclotron for every patient, which wouldn't be very efficient. And you'd need to have your cyclotron pretty much in the same building as your patient. So in Cambridge, it's the cyclotron sits underneath the PET scanner. So there's no direct route. So the little man still has to run out one door, along a corridor, up a flight of stairs, along another corridor, and then into PET. So we haven't quite got the sort of vacuum tube approach yet, where some places have. Now, because you only have about 20-minute half-life, if you're doing 10-15-minute bed positions, you sort of run out of bed positions after about 4 runs. So we can only really see one part of the body. It also has normal uptake in liver and gut, because if you could think about it, they're dealing with amino acids all the time. But it's very good for head and neck and thoracic tumors, and have been used, as I showed you yesterday, in parathyroids and pituitary tumors. So just to remind us, this is a pituitary tumor, and this is a big one causing acromegaly. And again, just what you can see here is the very intense uptake in the tumor and almost no uptake in the surrounding tissue. So you get a very good target to background ratio. This is a slightly different patient. This was a patient who had an ACTH producing tumor, but the pituitary fossa was normal. So we knew that it had to be a pancreatic ACTH tumor. And we tried to find it, or tried to prove that was the case, but we couldn't do that. Partly because the pancreas also has uptake of C11-methionine, but we did a few extra bed positions. And here we have a left infraclavicular node. And those of you who remember your anatomy will know this is a Virchow's node. And so you get this node when you have nodal disease in your abdomen. And it provided a site for biopsy. And from then, they showed that there was indeed an ACTHoma. Now, the other interesting thing about ACTHomas is that they obviously result in a high steroid production. And those steroids block gallium-68 dotatate. So they're often negative on gallium-68 dotatate, which we found out on this patient. So tumor cells, because they basically grow quickly, they basically outgrow their blood supply. And when you do that, then oxygen levels drop, what we call hypoxia. And this releases various different peptides, human ischemic factor, and epidermal growth factors. And these try to get new blood vessels to grow in. Now, you may say, well, that's a stupid thing to do. If the body didn't have these hormones, then we wouldn't have all these tumors. But of course, it's not designed for that. If, for example, you had not much a complete infarction, but severe ischemia in your heart, these mechanisms would protect your myocardium because they would bring in new blood vessels to protect your heart. So these are really sort of rescue systems which have been purloined by the cancer, been taken over by the cancer, but they're there to rescue other ischemic tissue. If you can get enough FDG, and if there's enough blood supply to get FDG in, these areas are often quite active on FDG, and they may well have a very high SUV. And you can see that sometimes in the heart where the patient just had a recent MI. Also, many drugs that are given rely on oxygen, as does radiotherapy, because radiotherapy is all about producing oxygen radicals, and a lot of drugs are oxidizing drugs. So if you have low levels of oxygen, then these agents are less effective. So this was from Caltech, which is, as you know, university in Los Angeles. And this was basically showing that what happens is as the cells become more ischemic, they start to secrete proteins, and this generates this antibody HIF, human ischemic factor, and then that stimulates the vascular epidermal growth factor, and you get the angiogenesis. So if you could block any of these points, then you may have a cancer treatment, and lots of cancer treatments attempt to do that. Bevacizumab, used in colon cancer, for example, blocks VEGF, and cetuximab does the same. So can we image this? Well, the problem with FDG is, yes, you do get uptake in hypoxic tissue, but you may also get uptake in metabolic tissue, so it's a bit non-specific. So we use a different trace called FMISO, which is diamazole ester. Now, where this is, there's enough oxygen, this ester splits open and the products are expelled from the cell, so they wash out very quickly. But if it's hypoxic, then the substance doesn't break down, it stays in the cell, and you can image it at around about 1 hour. Again, we can't really do the whole body, we can just do bits of the body. You can also use a copper-64 agent called ATSM, which is very similar ester. People have tried to look at angiogenesis, and they have this thing called an RGD peptide, which links to the alpha-5 beta integrins, which are part of the EGF system, but they've not really taken off. So this is a study that was done on a patient with kidney cancer. And if you look at the MIP image first, you can see there's a whole row of uptake. This is not FDG, this is FMISO. So this is hypoxic tumor. And you can see how intense the uptake is. So these cancers are really, really hypoxic. And what do we know about kidney cancer? Chemotherapy doesn't really work. So there's a link there between the high level of the FMISO and the chemotherapy not working. So I talked about IgG peptides. This is flucitamide, which I think is about to get licensed in the United States. I think it's going to become a licensed product. And this is a patient with a glioma. You can't really see it very well on the CT, but there is a sort of low density area here. And what you can see is a ring of uptake here, and that ring of uptake is around the edge of the tumor, and it's around the edge where you get this angiogenesis. So it's picking up that angiogenesis edge. So this is very much looking at angiogenesis, and it works well in the brain because you don't have any uptake in normal brain. So that's where it may well get used. What about apoptosis? Lovely word, isn't it? Apoptosis. So apoptosis is programmed cell death, and it's a part of a normal process. So it's calculated that we totally renew our cells, except for our brains, every 7 years on average. Now, of course, there are some famous American singers like Cher who renew themselves about every 2 weeks, but that's a different thing because that's plastic. But in terms of our own tissue, they renew at different rates. So facial skin, for example, renews every 2 to 3 weeks. Your gut is every couple of weeks, but your bones are about 7 years. So if you're building new bits, you need to get rid of the old bits. So the body does what COP26 didn't do in Glasgow. In fact, it's a very efficient recycler. So as all these heads of state went off and declared why they couldn't stop the planet from having climate change, the human body gets on with the act of recycling very, very efficiently. And so there's a process that goes on which enables the cells to be broken down and the building blocks reused to build new cells. And that whole process is controlled by something called P53. Now, there's two types of P53. There's the wild type, which sounds exciting, but is in fact very boring because it just does normal stuff. And then there's the mutant, which also sounds very interesting, but it is sort of interesting. And if you have a mutant P53, then your cells don't break down and they become immortal. Now, let's go back to apoptosis. What happens is that during the process, it's about a 10-day process. The cell wall forms blebs, and then it starts to turn itself inside out. And that enables macrophages to basically eat all the contents and recycle the amino acids and glucose and everything else. So most people have tried to use something that looks at this reversal of the cell wall. And it can be quite quick. So, for example, one of the proteins that's exposed is called Annexin 5, and this can be exposed within 24 hours of giving an effective chemotherapy, which induces apoptosis. So this is a sort of picture of what I was trying to explain. Is that they start off as a normal cell. Then once the process starts, it doesn't stop. You can't stop apoptosis. Then you get these blebbings, and then it also turns itself out, and then you've got lots of little bits that get eaten up. So people tried to do Annexin 5 imaging. This is from Chris van der Wiel, who is a great friend of South Africa, been many times to help with various research projects, working in Belgium. And here we have some lung cancers and some lymphomas. And you can see in panel 2 and 4, these are done on 24 hours after the first chemotherapy is given. And you can see there's quite intense uptake. And this is meant to correlate well with tumor reduction. It seems to work better with Hodgkin's disease than it does with lung cancer. Other people looked at other agents. This is a fluorinated Annexin 5, basically just been done with rats. And it does show that there seems to be increased uptake when there is hypoxia. Other people looked at caspases. So caspase is an intracellular protein which is used in controlling DNA. And this isn't a study which has been looking at uptake in cells which are just bathed in saline, then bathed in cyclohexamide, which is the stuff that's in your hand gel that you rub on your hands every time you go in and out of your clinical rooms, and is often in the hand gels that they have at shopping centres and stuff. So it's an antiviral, anti-everything, anti-bug. If you drank it, it'd be anti-U as well. So it produces quite significant cell death, and it shows that there's increased uptake in this rat model. This is a human patient with another agent called ML10, and this is a patient with testicular cancer that has been treated with first dose of chemotherapy, and there is increased uptake. And they do this thing called a tunnel test, which is the bottom image, showing that correlation between this uptake and apoptosis. Oh, I wonder when the value is going to come. So it is possible, and there seems to be quite a good correlation between the degree of uptake and the degree of apoptosis. Most people are heading towards Caspase 3 as the prime agent, but the problem is, do people really want to know if the drug's working first time? I think the patients do. I'm not always sure the doctors do. So somebody talked about FAPI. So this is fibroblast activation protein inhibitor. Now, this is an unusual agent, an unusual target. So it's a bit of what we call lateral thinking. As you know, one of the problems with FEG is it has uptake in lots of different cell types. So some people thought, well, why don't we not attack the cancer cell, but attack the support cells? And these are fibroblasts primarily. And they have these activation protein inhibitors on their surface, which we could label. And this is basically the idea. And the idea is to try and produce something that is a bit strange enough. By not targeting the cancer cell, we may be more specific than things that target the cancer cell. And also we have low background. So when you're doing an FMISO PET scan, you've got moderate background in the liver, a bit in the lung, a bit in the blood pool. There's a bit of haze around the spleen, the kidneys are always hot, the bowels are always hot. So, we get a lot of background activity, and it's very difficult to see small lesions. So the idea is if we could have something which had less background, that would be good. So this is the structure of FAPI. It's terribly simple. Okay, so it's just a ligand that attaches onto this fibroblast proliferation inhibitor. Very, very simple. And it's very easy to, because it's got a couple of nice rings on it, it's very easy to fluorinate. So those of you who may have seen this picture from the SNMI, the last time there was a proper SNMI, before everything went completely bananas. And this is a series of different cancers. So there are here 15 different cancers imaged with Ga-68 FAPI. There are a couple of issues. You can see bone marrow activity, but it's not, you can still see some bone marrow tumor in the bone marrow, so it's not as bad as it is with methionine. You do get some kidneys and bladder. You don't really see normal liver, which is good. And the most important thing is you don't see normal brain. So you can pick up disease in the brain. And there's not that much gut activity either, which you get with FDG. So all in all, a very interesting agent. So a very recent paper came out again, probably, I think July in EJNMI, investigated 68 patients with Ga-68 FAPI, with suspected cancer, but equivocal. So if you look at this one, they're all riddled, aren't they? They've all got tons of cancer. So to be honest, most people can find that. This is much more interesting because this is looking at patients who may only have a small amount of cancer. And but the FDG scan wasn't very helpful. And 87% of these patients had increased uptake of FAPI compared to FDG. So that could be very interesting. However, big problem here is that fibroblasts are deeply involved in inflammation. And FAPI was invented about 10 years ago as an inflammation agent. So you still can't rely on FAPI alone. you still would need to do a biopsy. And about a third of these patients were found to have inflammatory tissue. Not so much infection, but inflammation. Though people have suggested using FAPI for looking for lung damage in COVID, and there's a couple of projects now running on that. There's one in London looking at that. So as long as you're aware of that, it's not a problem. But so if you have a patient who's got a known cancer and you're looking for metastases, there probably are going to be, that's where the FAPI is. But if you don't know if they've got cancer, then you can't rely on FAPI alone, you still need a biopsy. The next new thing on the block are the fluorinated estrogens, estradiol. So this is from a paper from a journal called The Oncologist, and this came out in April of this year. And this is a patient who has a breast cancer, because estrogen is related to breast cancer. And this patient had uptake of the tracer into their lymph node. Now this is an FDG, and this patient had been treated with tamoxifen. It's a bit of a chunky lymph node, so it could well be positive, but when they do the estrogen scan, there's no uptake. Now this could be important because when you treat breast cancer with either Herceptin or immunotherapy or hormones, the FDG uptake goes up because of the inflammation that occurs around the tumor. So if you do a scan and then start the treatment and then rescan them 6 weeks later, you may convince yourself that the patient's getting worse because the FDG uptake is going up. But in fact, they're getting better because it's causing an inflammatory reaction, which will eventually kill the tumor. Whilst using the estradiol, you get a much more specific answer. So we've not really seen this agent in Europe. It's only been in the US. It's actually a approved and marketed product in the United States. And all the literature is really from the United States. So we haven't really had any experience with it. But they claim it changes patient management in 24% of patients. So the last bit we're going to look at are these things, these very, very sexy things called the checkpoint inhibitors. So checkpoint inhibitors are basically a way that the cells can block damage. So what happens is that, let's say your body's immune system says, there's cancer, and it starts to want to attack it. So your T lymphocytes head off to get your cancer cell. But the cancer cell has a checkpoint inhibitor called PD-1. And what this does is it basically stops the T cell from attacking it. That's why it's called a checkpoint. So it's like if you drive to Lesotho or Eswatini, there's a barrier across the road and you've got to show your passport and they kind of stamp it and stuff, and then they'll lift the barrier and let you in. That's a checkpoint. So it's a similar kind of checkpoint. Now, there are lots of drugs which are now designed to try and block this checkpoint to enable you to attack the cancer cell. But can we use functional imaging to help us with this? So this is some fairly new work, which is looking at FDG and checkpoint inhibitors. So this is in melanoma. So the 3 pictures across the top is a pre-treatment, and then there is 4 weeks after treatment, and then 4 months after treatment. And if you look on the CT scan, and to help you, there's a red arrow. It starts off with a particular size, then it gets bigger, and then it gets smaller. Okay. And this patient has been treated with one of these new mTOR inhibitors. I can hardly pronounce it, ipilimumab. Okay. So the question is, what's going on? So, and this is a drug which is blocks these checkpoints. So it should allow the body's own immune system to attack the cancer. So when you're doing serial PET scans, you get the same kind of appearance. First of all is the active tumor, and then 4 weeks in, it all looks worse, doesn't it? But in fact, what that is really recording is that there's a battle going on there between the tumor trying to block the body's immune response and the drug trying to remove that blockage. And that results in lots more inflammatory cells coming in. So you have an active inflammatory process. So what you're seeing is effectively the battle scene. The middle colored image is the battle scene between the patient's own immune system and the patient's cancer. And this drug, ipilimumab, is trying to unmask the enemy effect. So if you can imagine, you have one army and the other army all in camouflage, okay? So that one army is trying to attack the second army in camouflage, and that's what happens in normal cancer. And then this drug comes along, and it's a bit like it rips off all the camouflage jackets, and underneath the camouflage jackets, they have one of those hazmat jackets. They're bright yellow, so everybody can see them from 20 miles away. And that's effectively what these checkpoint inhibitors do. And then what you can see is when you do the subsequent FDG scan, the lump is still there, but the cancer is dead. And it basically stays dead. So this is from the JANA in 2017. And there's some work that was published a couple of weeks ago also showing the same kind of thing in different cancer. So you can use FDG when you're looking for these very, very precise cancer treatments, but don't be fooled by early change, because early change may be an increase in activity, not a decrease in activity. It's very important when you're reporting all these fancy pants immunotherapies and different types of new treatments that you don't, let's say you do it within 3 or 4 weeks of starting treatment, you have to always put a caveat, is that we don't really know what's happening with this, with FDG, with this treatment. I've seen lots of patients that seem worse, and then you scan them 6 months later, and the cancer's all gone. And melanoma particularly does that, and breast does that as well. You get this big inflammatory reaction when you got an effective treatment, and then the tumors just disappear. So in summary, I think that we will still be always a major part of oncology. We're not there really for diagnosis, but we can be used for staging and reassessment. But very interesting is how we could possibly use more looking at cancer cells and its function, monitoring the effect of treatment, and maybe even how this idea of personalized treatment. I think that some of these will enter the field clinically. I think FAPI will, but particularly for research, it's very useful. And the best agents are those that are fluorine or gallium-68 based, because they can be either made locally or at least travel a reasonable distance before it's used. So these are the kind of agents that we're looking at. And I think that is it.